Okay, we continue with the last session of this morning. And my co-chair, I'd like to introduce Paul Klepper from Manchester, and I'm Mariette Veldkamp from Leiden. We will start off this session with a keynote by Ulrike Wieland. Ulrike, where are you? Over there already. Sorry, it's always difficult when you're sitting on front. Ulrike is from the University of Cologne, where she works since the mid-90s, last century, already some 25 years
yes,
ago.
last century.
Time flies. And the last 2 years she's chairing the German Reference Center for papillomaviruses and polyomaviruses. In these 25 years, she studied double-stranded DNA tumor viruses, especially papillomavirus, and we collaborated a lot on that in the past years. Since she started, I think she has over 100 publications on these topics, and you started with HPV-16 like all of us did in that time, but your last publication, I just checked, dealt with HPV-197. So, I mean, enteroviruses, but papillomaviruses also. Moving on. And last year's also some work on protoparvoviruses, the cutavirus.
Yes.
I don't know if you will address those.
No.
But, no. Okay. But
they don't cause cancer.
I'm sure
I can say
will,
this is what we believe.
Okay.
Yeah.
Okay. Well, the floor is yours.
Well, this is a very good morning, everybody, and thank you to you for this invitation. And this is a very broad field, and I decided to focus only on a small part of it because otherwise we get lost. I will give you a brief overview. Does this work? No, it doesn't work. Oops. I'll give you a brief overview on papilloma and polyomaviruses. Then I'll say something about Merkel cell polyomavirus because I think this will be more important in the future. Then I'll switch to oral HPV infection because we've been working on this recently. And in the last part of this talk, I'll show you some very rare clinical manifestations of human papillomaviruses. Up to date, there have been 226 classified human papillomaviruses and more than double or even more unclassified human papillomavirus sentences. On this upper part of the tree are the genus alpha papillomaviruses, and they infect our anogenital tract. It's about 40 plus viruses. And those on the left, the purple ones, are high risk or probable high risk papillomaviruses, and they can cause anogenital and other cancers. And those printed in bold are real high risk papillomavirus, and the other ones are possible or probable, and 16 and 18 are the most relevant ones. And papillomaviruses, here shown on the right, only infect multilayered squamous epithelia. This is an overview what kind of clinical diseases they can cause. They can cause diseases of the skin, of the head and neck region, and anogenital lesions. Those printed in green are benign lesions, like all kind of warts. Those printed in purple on the right are cancer precursors of the cervix, vagina, vulva. PIN stands for penile and AIN for anal. And those printed in red are cancers, invasive cancers. This is an overview of polyomaviruses. You've heard a lot of this about already yesterday. Right now there are 14 human papillomaviruses. In the last 3 ones, 12 to 14, are perhaps not human polyomaviruses. The last one possibly causes diarrhea in cats. And today I'll focus on Merkel cell polyomavirus, which is underlaid in yellow, because it is the only human polyomavirus that can cause severe disease also in immunocompetent individuals, not only in immunosuppressed, and it can cause Merkel cell carcinoma. And this, Marit, is your virus, number 8. She discovered it basically, and it's a very interesting virus that can cause this disease shown here in immunosuppressed patients. Yeah, coming to Merkel cell polyomavirus and Merkel cell carcinoma. Merkel cell carcinoma is a rare but very aggressive skin cancer, and it's more aggressive than malignant melanoma. It occurs basically only, not only, but in the vast majority on UV exposed skin, and it affects mainly people with white skin, which shows that UV light is an important factor. It affects elderly people and immunosuppressed people like HIV-infected patients, transplant recipients, and I already said it's a very aggressive cancer. The recurrence rate is about 40%, and the mortality is higher than that of malignant melanoma. And Merkel cell polyoma, which was discovered in 2008, is found in 80% of these cancers, and in this group it's approximately integrated into the human genome in 75%. And in these tumors, the polyoma virus tumor antigen, large tumor antigen, is expressed, which you see down here. And these are some examples of Merkel cell carcinomas. This one was misdiagnosed as a benign lesion, and this is metastatic. We've previously looked on the prevalence of all these polyomavirus on the human skin, and this was a single forehead swab of healthy individuals. On the right, healthy men, and on the left, besides their HIV infection, healthy HIV-infected patients. And in this one-time swab, we found it in 50% and more frequently almost 60% in HIV-infected patients. And if you look in sequential swabs, you find it, more than 80%. And this is what you've seen yesterday. This frequent exposure translates into serology. This is from the group of Marit. We had this very lovely presentation yesterday. And this is a seroprevalence here pointing to it of Merkel cell polyomavirus. And already in the youngest age group, you see an above 80% seroprevalence. So almost everybody has contact with this virus. Why do I think it's important? Because we have seen, we have no really statistics, but this is one of the dermatologists we work a lot with, Alexander Greuter von Oberhausen. He has seen many of these cancers recently, and they come in a late stage, and basically all of them, this was metastatic already, died of this. And these are epidemiological data from the United States, and they show that Merkel cell carcinoma incidence is rising in an aging population. We all get older and older, which is good in a way, but we get more diseases. And this is from 2000 to 2013. The incidence rate rose from 0.5 to 0.7 in the United States. The cases, the absolute numbers, almost doubled, which is more than for melanoma, and more, the doubling is more, not the absolute numbers, more than the solid tumors, and the incidence really rises dramatically. This is all age groups, this is the younger age group, and this is people above 58 years of age. It really rises dramatically if you are above 58 years of age. And I think it's important to realize this, because if we have expanded awareness of this, this is probably the role of primary care physicians, and if you see this early and treat it and have a histological diagnosis, then you can heal the patients, and if it's diagnosed too late, you'll die of it. This is a test that could be important for clinical virologists. This is why I show it in the future. It was developed in Seattle, where there's a center in the US for Merkel cell carcinoma, and they found out that about half of the patients with Merkel cell polyoma produce antibodies to the large and small T antigen, and within this patient group within the group of patients that have these antibodies, a rise of these antibodies shows that the patient is developing recurrence. And in this very recent publication, they showed that this test in this patient group is better than imaging. So this could be a test that could be important to all of us if we see this rise of Merkel cell carcinoma in the future. Yeah, then I come to oral HPV infections. Why is it important to know more about the natural history of oral HPV infection? For one reason, the proportion of oropharyngeal cancer that is HPV positive is rising. These are, on the right, early data from the United States. Here around 20%, and in the later years, it's 2000, 2004, coming close to 80%, and this has been seen in many countries. These are data from Germany, here up to above 60%. And you see a steady increase of HPV-induced oral carcinomas over the years. This is a big meta-analysis that was done, and 64 recent studies, and HPV prevalence in tonsillar carcinoma and in base of the tongue carcinoma, which are lymphoepithelial tissues, are 60 and 40%. And the other sites in the oral cavity, they are less frequently HPV associated. It's not only the proportion of HPV positive cancer that's rising, but it's although the incidence in general. These are again data from the US, a sharp rise, interestingly only in white men, not in the other skin colors, and a milder rise in women. And we see this mild rise also in Germany for women and for men. This is a very interesting publication from the United States. They looked at HPV-associated cancer from 1999 to 2015, and what you see, cervical cancer in women is falling, and HPV-associated oropharyngeal cancer in men, this line here, is rising. And in the year 2015, they had for the first time in absolute numbers more HPV-associated oropharyngeal cancers in men than cervical cancers in women. And all these printed in red here on the right, all these cancers are rising in the United States, and the blue ones, penile and vagina, they are basically constant. And similar numbers are seen in other countries. And because of this, it's important to know more about oral HPV infection. Can be found in different studies, below 1 to above 20% in healthy adults, and most infections are transient. This is population-based studies from the US, performed in 2009 and 10. The volunteers gave an oral rinse, and overall HPV prevalence was close to 7%, and higher in men than in women. The most frequent type was, high-risk type was 16, and there was a rise in age. This is a bit later study, 2011 to 14, basically the identical results, around 7% overall, higher in men than in women. This is hair-rich HPV, and these are the individual types. They are all blue are men, green are women. They are all more frequent in men than in women. A meta-analysis of many studies showed quite a variability, but overall it's the same, 7%, 9%, and lower in women. And this study, also a systematic review and meta-analysis, looked at the different continents. In Europe was number 1, which you see here on the right, and in Asia, oral HPV prevalence is lower. And in all continents, HPV-16 is a most frequent type. What are risk factors? All these risk factors named here: smoking, male sex, age, if you have a genital HPV infection, or your partner, severe periodontitis, probably because the virus gets more easily to the basal layer, and perhaps alcohol. But the main risk factor is a number of oral sex partners one has. If you look down here, men with 5 or more oral sex partners that were smoker had an oral HPV prevalence of almost 15%, and those with 1 or less oral sex partner, 1.7%, and lower in women. Important is not transient detection of HPV, that probably does not play a role, but persistent oral HPV infection. And this study here looked on persistent oral HPV infections. 23 patients had HPV-16, And of those that had prevalent HPV infection when the study started, 40% persisted over 4 years, and none of those with incident infection. And again, age was a risk factor. These are other studies, and they found persistent rates 0 to 44%. These numbers printed in green. And what is missing are long-term studies that go beyond 6 years, because probably these carcinomas take longer than 4 years to develop. Here are oral HPV infection in HIV-positive men. They have the same risk factors as shown for non-HIV infected, and this is an additional risk factor, of course. Low CD4 counts, you have a higher risk of oral HPV infection. We recently did a study, a long-term study, and we are still doing it actually, it's not finished, on HPV infection of all sites on HIV-positive men who have sex with men. We began this in 2004 and it's still ongoing. These are the oral data from until July 2018. We had 900 subjects at baseline and 721 delivered 2 or more swabs. The men were between 18 and 80. Most of them received antiviral therapy and about half of them were smokers. Altogether, we had over 4,000 swabs, and these are the 721 patients that delivered 2 or more swabs. They delivered a swab in average every 12 months, sometimes more frequent, and the median number of swabs was 4, and the median follow-up time close to 16 months, and the longest one was 160 months. We did HPV typing by a bead-based Luminex assay that was developed in the DKFZ that covers 43 HPV types, 20 high-risk or probable high-risk, and 18 low-risk types. And we determined oncogene messenger RNA expression in the oral cavity using the Aptima assay that covers 14 high-risk types but does not deliver type-specific results. These are results at baseline. 26% of the men were HPV positive, 15% high-risk HPV positive. And what you see down here are the individual HPV types with increasing number, HPV2 on the left and HPV 177 on the right. And those types printed in red are high-risk types, the orange one are probable high-risk types, the blue ones are high-risk types covered, theoretically covered by the nonavalent vaccines. The green ones are low-risk types, and the purple ones, HPV 6 and 11, are low-risk types covered by the vaccine. And you will see this slide, this graph in all the following slides. Here we discovered 49 different HPV types, and the most frequent ones were 16, 45, and 72. And quite a lot of patients had more than one type in their swab. The maximum was 10 types in one swab. These are the types detected within the whole study period. Almost half of the patients had oral HPV. Again, the most frequent type was 16, followed by the other ones shown here. These were incident infections. 31% of the patients had incidence infections, 16.8 incident high-risk infections, and 55 different HPV types were detected. Again, HPV 16 the most frequent type. And this slide is one of the most important ones. It's about persistent infection. 12% had persistence was defined as the same type in consecutive swabs. 12%, which was 44% of all patients that were high-risk HPV positive. 64 different persistent HPV types were detected, and of those, 93 patients with persistent high-risk infections, almost half had HPV types that would not have been covered by the vaccines, and these are the types shown in orange and red. Now, how long did this infection last? This is most frequent persisting types, HPV 16 on the top. The median duration was 47 months, and more than or 75% lasted longer than 24 months, and half lasted longer than 48 months. Interestingly, all HPV-33 infections lasted longer than 48 months, and the longest duration of infection, of persistent infection, we could measure was more than 11 years for HPV-33 and HPV-58. Risk factors were age, and there was a trend for smoking as a risk factor, but it was not significant. Then we determined HPV DNA loads for these 6 high-risk types, and it was defined as HPV DNA copies per beta globin gene copies. And smokers, shown here on the right, had significantly higher loads, HPV high-risk loads in their oral cavity than non-smokers. This slide is about oncogene messenger R expression. We analyzed so far 176 HPV DNA positive swabs of these patients and 9 HPV negative controls. And of those that carried HPV-16 DNA, almost 1/3 expressed the oncogenes E6 and E7 in their oral cavity, and it was less in those that had high-risk types not other than HPV-16. Yeah, what lesions did these patients develop? Almost 6% of the patients had oral lesions in the cavity. It was mainly benign condylomas of warts. 1 patient had HEC disease. 8 patients had oral intraepithelial neoplasia. And these numbers printed in green are the types that we found in lesional biopsies. In their swabs, they had all kinds of types. And those underlined are the types covered by the vaccine. And you already can see that the majority is not covered by the vaccine. And interestingly, HPV-6 and 11 that are found usually in anogenital warts were only found 4 times, and HPV-7, 40, they were the most frequent types in these anogenital warts. Within the study period, no patient developed an oropharyngeal cancer, but 3 patients developed SCC of the tongue after they had unfortunately left the study, and their biopsies were not available, so we could not look if they had the same types in these cancers that they had had before. Yeah, HPV can be found in the tonsils, in the crypt of the tonsils, and there are discontinuities in the basal membrane, and they seem to facilitate the access of HPV to these tonsils. Now, how frequent are HPV in pediatric tonsils? This is a summary of all studies, and there was a large variety between 0 and 21%, and the largest study from the United Kingdom with 1,670 samples didn't find it in any samples. This is a map of this study. United Kingdom 0%, and Belgium, which is just across a channel, they found it in 21%, and there's really no good explanation for this wide variation. We have looked in a smaller number of healthy tonsils recently. On the right are cancers, and we found there tonsillar cancers in almost 50%, and these cancers really had high viral load. We also found it in 2 young women, but in contrast to the cancer sample, the viral load was really, really very low. Here are human polyoma viruses. We found them occasionally in these tonsils, both in benign and malignant tonsils, but in all samples, the human papilloma virus, polyoma virus load was very low. These are other studies of non-malignant tonsil of adults, and they came to similar results than we did. 1% they found it in episomal form, here from China and Pakistan, in older individuals a bit higher than in lower, and this is a study from the US, 5%, and they detected particles. Well, I looked at this picture really very meticulously. Where the blue arrow is, you should see papillomavirus capsids, and they co-localized it with the biofilm of the tonsillar crypts, and they said this is a proof that HPV is replicated in the tonsillar crypts. But actually, besides this publication, it is not known whether we have productive or abortive infections. And also for the tonsils, in contrast to the anogenital sites, no real precancer has been described so far. Could this all be prevented? It probably could. There is no study that shows that HPV vaccination can prevent oropharyngeal cancer, but there are 2 studies here that have shown that people that these were the cervical studies, and it was not really the final endpoint, but they asked the women, young women, to donate an oral specimen 4 years after the vaccination, and these were vaccinated with a bivalent vaccine and these with a hepatitis A vaccine as a control. And they found it here only in 1 woman compared to 15 women, 0 to 9 women, and they calculated a vaccine efficacy of 100 and over 90% to prevent oral HPV infection. And if you look at the types found in oropharyngeal cancer, it's main here the cervical cancer for comparison. It's mainly HPV 16 and these other types here, and I circled in green all these types covered by the vaccine. So if we vaccinated everybody, we probably could prevent almost all, this here remains and this here remains, almost all oropharyngeal cancers, HPV-induced oropharyngeal cancers. And this is a population-based study from the US. They had a very moderate vaccination rate at this point in time, 18% higher in women than in men. And they also were asked to donate an oral rinse. And overall, these are the reported vaccinations, and these are the unvaccinated, overall women and men. And they didn't find oral HPV 16, 18, here the 4 vaccine types, in any of the vaccinated men, only in 1 woman. And overall, there was a reduction of almost 90% of oral HPV by the vaccination. Then they took these data and estimated the population level effect for the United States. And these are all the oral HPV infections with the vaccine types, women and men. And these gray bars are the reduction achievable with the current vaccination rates. And if we vaccinated everybody, these are the yellow bars, we could basically prevent all infections in men, almost all in women, and almost all in the overall population. Now, my last part, I'll show you some rather rare clinical manifestations of high-risk HPV infections that we have seen recently. This was a 70-year-old male, and his admission diagnosis was treatment-resistant herpes zoster. He had had this itching rash, you could call it perhaps, for more than 6 weeks here on his arm and on the chest, and he had already been treated with acyclovir and with primodine because they expected acyclovir resistance, and without any clinical effect. And what's this? It was not herpes zoster, it was widespread cutaneous metastasis of an HPV 16-induced periungual SCC that this man had had for more than 4 years, but nobody took attention of it. He was mildly impaired, mentally impaired, and lived with his sister, and nobody took care of it, and he ended basically up like this. This was excised. He received chemotherapy, electrochemotherapy for the metastasis. He had an initial response, but recurrence 3 months later, and eventually he died of a stroke. We have seen these periungual SCCs not frequently, but we have cases on and off. These are 6 of them. It's not only HPV 16, 51, 33, 73, and these other types. And all periungual SCCs from the hands we have seen were high-risk HPV associated. On of non-periungual SCCs of the hands that were located on the lateral fingers or back of the hands, only 1. They all express P16, which is an indirect marker of HPV oncogene expression, and they invade or progress to invasive cancer pretty fast. And this is something new. We are just started to analyze. We have seen, meanwhile, the number is 4 HPV-induced cancers. Here are shown 2 of the feet. They are all from this year. This was a 78-year-old woman with basically no diseases, and she had had these lesions for more than 18 years and had had numerous treatments for fungal and bacterial infection. And the second woman was younger. She also had an unremarkable medical history besides heavy smoking, and she also had had these lesions for 2 years, and she also was treated for onychomycosis, and it didn't go away. This was why she were transferred to the hospital. And both were HPV-16 induced, strong HPV P16 expression, which is an indirect marker of HPV-16, high-risk oncogene expression. This was an invasive cancer, and this was cancer in situ. And in both cases, there was a significant delay, 18 years, 2 years in these patients. And meanwhile, we stained all SCCs that we got off the toes in the last years with P16, and we found 2 more that had a high 16 load and a 45 load, and the other ones, which are 9, we are just about to analyze, that were about half of them were P16 positive. Though it's a riddle, how does HPV-16 get there, but these cases seem to exist, and there's often diagnostic delay. So this is a summary. First, the oral part. The proportion of oropharyngeal cancer attributable to HPV and the incidence of HPV-positive oropharyngeal cancer are rising. Oral HPV DNA can be found in 3 to 11% of the general populations, more frequently in men than in women. Most infections seem to be transient. The main risk factor is the number of lifetime oral sex partners. Oral HPV prevalence is higher in HIV-positive patients than in the general population, and they also, I haven't shown this, have an increased risk for oropharyngeal cancer. In these patients, 50% of oral HPV-16 lasts at least 48 months and some up to 11 years. HPV prevalence in non-malignant tonsils, both of children, healthy children, adults, is low, and probably HPV, prophylactic HPV vaccination could prevent the vast majority of these oral HPV infections, and as a consequence, probably also could prevent oropharyngeal HPV-induced cancer. MCC incidence is rising in our aging populations. We need to be aware of it because early recognition, diagnosis, and treatment saves the patients. About half of MCC patients produce antibodies against MCC oncoproteins, and rising titers seem to be a very good marker for recurrent disease. In contrast to other locations on the hand, this is the HPV part again, periungual SCC are frequently associated with high-risk HPV, although they are altogether a rare disease. And recently we've seen SCCs of the toes in immunocompetent patients, also in immunosuppressed, that are high-risk HPV associated, and the diagnostic delay in these patients was considerable because it was confused with fungal or bacterial infections. This is what I wanted to tell you.